Hey, Casey, can you hear me okay? Casey, would you be able to share your screen with the slides? Benjia, can you hear me?
Yeah, I can hear you, Professor.
Okay, great. Can you, maybe I haven't shared my screen. Um, okay, I'm going to share my screen now. Can you see my screen okay?
Yeah, it's good.
Okay, great. Casey, are you there?
Yeah, I'm here, Professor.
Oh, perfect. Can you share your screen? I'm going to stop sharing.
Sure.
Perfect. So we're all going to have to try and stay on time. We've got how many we got to get through here? So we have one, two, three, four, five, six, seven, eight. So we're gonna go on 10-minute intervals. Okay, so everybody's got to stick to 10 minutes. Hope that's possible. So I think you can get started, Casey. We're at 9:30, so recall you have 10 minutes to get it done. If you want to leave like a minute for questions, that would be great. So fire away.
Okay, sounds good. So, hi guys. So this is my partner Bryce and I's project. So our project will be about deep learning based dual phase segmentation of the left atrium and left ventricle across the cardiac phases. Oops. So this is a brief overview of what image segmentation is. It's the process of automatically delineating anatomical features of the heart for medical imaging. So it is critical for the quantitative process assessment, specifically for cardiology images, um, is its heart structure, function, disease diagnosis, and treatment planning. So these are the current state of the arts for image segmentation. There's some um, 3D modeling that is the state of the art. So there's different um, deep learning algorithms such as UNet, TransUnit, and UNet-R. So they're all slightly different as the models are trained based on the images that are used as the inputs for these models. But we found that a common deficiency that these current models have are that they only are specific towards one subset of data, whether it be only the left atrium or the left ventricle data, and likewise only measure the end systole or the end diastole data. So our goal eventually. So our objective is we aim to develop a deep learning pipeline that employs dual phase segmentation, which would include data from both the left atrium and the left ventricle, as well as take into account the end diastole and end systole data for 3D cardiac images. Then the system will leverage annotated mask verified via the ITK snap and will enable downstream computational functional cardiac metrics like ejection fraction. So, with the dual phase segmentation, we aim to address a part of these deep learning 3D mask algorithms that is currently not addressed, and hopefully bundle that into um, one big deep learning algorithm.
Okay. So first, about the data set, we need to thank our Professor Dr. McVeigh for providing the data set. And so in terms of data set, we have 40 cases of 3D cardiac images in Nifty format, and each case includes both end diastole and end systole phases. And we have the annotated ground truth labels for the left atrium and left ventricle. And we, and each file, yeah. So basically these are our training data. And next slide, please. So this is our data open in ITK Snap. These images show our segmentation labels. So the left panel is the left ventricle segmentation in the red, and the right is the left ventricle segmentation. Um, the multi-view display shows the axial, sagittal, and coronal planes, respectively. Next slide. In terms of our methodology, we first will do our data pre-processing, which includes reading the Nifty data using the Babel and normalized intensities using z-score or min-max scaling, and resampling to consistent voxel spacing, and resizing to uniform dimensions. And last, we'll do some augmentation um, to comprehensively train our data. Um, and then it's our model architecture. We aim to use some of the state-of-the-art network to implement them in maybe TensorFlow in Python. And then the input will be our 3D image volumes with dual phase. So we'll couple them together to get our 3D image. And then the output will be segmentation mask for the left atrium and left ventricle. Probably will do output channels for both of them simultaneously. But we're gonna train the ED and ES jointly, and we'll evaluate our output with the ground truth documentation using some evaluation metrics like dice, dice coefficient, and cross entropy, etc. And that's what we have so far. Thank you.
Okay, great. Thanks for being well under time. So if I can ask a couple of questions, when you go for the augmentation and you said one of the augmentations or two of them you're going to do was flip the images and rotate the images. I'm not sure why you would ever need to segment images that were flipped. Um, so to sort of broaden the network in that direction, I'm not sure what the motivation is there. Rotation, many hearts come sort of slightly rotated with respect to each other,
Mhm.
within about 40 degrees or something like that, but I don't really understand the flipping.
Um, I think it's just basically what the state of the art, like it's different images for sure. So I think we'll just maybe do the rotation if we see some of like the angle shift in our images. But if not, we can definitely just get rid of the augmentation step.
It, I think it would be good also in the project to perhaps explain why certain augmentations are used and others are not. Because obviously there's an
Hmm.
infinite number of augmentations we can do, and you're selecting a finite number. So probably some of the theory behind how you select those augmentations be a good thing to include, I think.
Yeah, that'll be definitely something we will consider.
Okay. And so just so I get it right, the thing you guys are doing differently than what has been done before is you're saying before networks were trained on either end diastolic images and that's it. And then they were trained on end systolic images and that's it. And you guys are saying we're going to throw it all in the same network, end diastolic and end systolic. They're going to go in as pairs and you're going to train that way. Do I understand that correctly?
Yeah, I think.
Okay. So their pairs of images are going in for training as opposed to separate networks. Okay,
Mhm.
great. Thanks.
Yeah, thank you.
Okay. Any questions from the class on that? We have maybe 2 minutes and
I have one question, like
yeah,
one question.
sure.
What were your evaluation matrix again? Like, what will they tell you? I think I missed that part. It was like the last slide.
Okay. So the evaluation metrics is basically so we get our output, which is our segmentation of LV, LA, and LV. And then we have the ground truth, and we will just compare those two by using, because they're like two basically images. So we'll use like, so it called like dice loss and cross entropy. So it's basically just comparing two images and see how like similar they are.
I see. Okay, that makes sense. Okay,
Yeah.
thanks.
Yeah, for sure.
Diana or Benjia, can you take the screen and Casey, you can release the screen. Yeah, thanks very much. Perfect.
Okay, let me. Oh, no. Okay.
Awesome.
All right. Hi, morning, everyone. My name is Benjia and my partner is Diana, and our project is on calcium granule detectability and motion. Okay, so first, a little background. We're focusing on coronary artery calcification. This is when you have like buildup of calcium in your coronary arteries. This can start from when you have plaque buildup that results from high cholesterol, diabetes, smoking, and high blood pressure, and that can calcify. Or like in the last lecture, when the professor said the repair process for like lesions can also leave behind like bone structure or deposits, and that can also be a source of this calcium buildup. And this is extremely dangerous because it can narrow the arteries, restricting the blood flow, which can cause very fatal heart attack and strokes. The motivation for our project that we plan to propose today came from this paper. This group looked at high resolution micro CT imaging for characterizing microcalcification detection in breast CT.
However, when you compare it to coronary CT, cardiac and respiratory motion are unavoidable and they likely blur small calcifications, and this reduces the detectability. And so, our aim is to extend this group's methodology by simulating and validating the impact of motion blur on calcium detectability in coronary imaging. So, this group just looked at stationary and breast CT microcalcification, and we plan to just look now at combining motion in coronary. Some background on CT acquisition and recon. So we know that as the gantry rotates around the patient, like this figure here, each detector row measures 1D line integrals of X-ray attenuation at a given view angle. And then stacking these 1D projections over all angles form a sinogram. And this is just a 2D representation of where one axis is the detector position and the other is the rotation angle. And then to turn this sinogram into an image, you'll apply a high-pass filter in the projection domain, then back project each filtered view into the image space. This process reconstructs the cross-sectional slice, and then each pixel in the resulting image is calibrated to this Hounsfield units, which measures the attenuation. Now, because the gantry takes on like 300 milliseconds for a full rotation, any structures that move, like a beating heart, will smear across multiple projections. So in cardiac CT, this effect can make any coronary calcifications disappear or dip below that 130 Hounsfield cutoff, reducing the sensitivity and any clinical confidence. The clinical challenge here is that coronary artery disease is the leading cause of death worldwide. Early detection is crucial, particularly in identification of these coronary calcifications. And the challenge here comes with motion during imaging. So, due to the heartbeat and breathing, this can blur or obscure any small calcifications, reducing their detectability and clinical value. Our hypothesis is that coronary artery motion significantly impacts the detectability of small calcium granules in CT imaging. And the research question being asked here is, how does coronary artery motion quantitatively affect the detectability of small calcium granules, and what amount of motion can obscure detection beyond clinical thresholds?
Okay, so I'm going to start with the plan for our project. So our first simulation that we're going to do is going to quantify how linear motion blur degrades the peak Hounsfield unit signals of a point like calcium granule and help determine the total displacement at which its reconstructed amplitude falls below the 130 Hounsfield unit detection threshold. So first, for this simulation, we're going to take a simple phantom that could take the shape of a square, a Gaussian like dot, rectangle, oval, or circle. And we're going to basically move that. And the way we're going to model that is basically have different frames of the shape at different positions. And then we're going to take the radon transform of each of those frames and then use those sinograms to reconstruct this final one to represent like the scan that would be taken if this thing was in motion. So to show it with like a toy example that we did. So on the left, this shows three boxes that are 5 pixels wide. And they're like each position is 3 steps away from the previous one, so they're kind of overlapped on top of each other. But they're supposed to be three separate frames, and then I took the radon transform of each of them separately, and we just assumed that it was moving at a velocity such that like the first 60 projections, we see the first position, the second, we see the second position, etc. So this is how I pieced together the sinogram. So the first 60 degrees of projection was taken from the first sinogram and so on. And then the box intensity, we made it to be 150. And then this is the final reconstruction from the sinogram pieced together. And as you can see, there are artifacts from that motion, and the maximum pixel intensity of the original calcium location was attenuated to 115. And then the way we define the original location is by the first position of the pixel, or not the pixel, the calcium box.
So for our second simulation, we want to extend this by looking at patient data sets. So CT data sets of patients that have calcium in their coronary arteries. And the objective here is, can we recover the true stationary calcium amplitude from the CT data and quantify the motion-induced signal loss from gated CT? So how we would go about doing this is, first we would acquire the cardiac gated CT series. Then we would have to measure the signal. So drawing an ROI over the calcium, record the measured peak and displacement of the calcium between that phase and the reference. The reference here we chose an end diastole because in that case there would be little to no motion. Second step would be to estimate the blur kernel. So compute the motion point spread function length. For each phase, estimate the effective motion blurring kernel length. And we can do this by simple displacement equations. So the length here at phase I would be equal to the velocity times the time projection. And then we can get the velocity here by the equation, just the displacement in millimeters or pixels divided by the time phase. Time phase is just the time span of the cardiac phase. And then once we have the velocity, we can convert this to blur length. The time, just to mention here, the time projection, this is just the CT's integration time for the projection angle. So once we have that, we can model the blur's effect. In this case, we just assumed that the calcium behaves here in this case as a 1D box, similar to the first simulation, but we can change this profile shape. So if you convolve box in a box, you get this triangular shape. So here A true is the amplitude, and then W is the width, and then the length I. So here we just did a convolution. The ML here denotes the measured blurred peak amplitude of the calcium profile after it has been convolved. So A true is the motion-free peak in Hounsfield units you'd see if there was, again, no motion. And then here the final step is we can invert this equation, the blur equation, to solve for A true. And these are our references that helped us guide for this calcification project. And then the dataset availability will be provided by Professor Elliot McVeigh. Thank you.
Thank
Great.
you.
Very nicely done. I love the preliminary data. You're right on the right track, I think, on how to do this and change your simulation to, be more realistic to, higher degrees of sampling and things like that when you have the compute time to do it. Looks like you're on the right track to figure this thing out. The one thing I would caution, though, is that it may not be a simple convolution blurring, right? So if I have something and I blur it into a broader thing, with CT motion artifact, some of it is blurring and some of it is just, it gets mismapped to a different location. So that's something you should keep in mind. This is probably not going to boil down to I can just convolve my image and then I'll get the motion artifact image, right? So, but it's an interesting sub-project is like, when can you do that and when does that not work, right?
Yeah. Okay, that's a good point. Yeah, we'll consider that.
Yeah, thank you.
Any other questions from the group? On that one, that was really great.
Thank you.
All right. Let's see who's next up here. Marco, you're next up.
Can you all see everything okay?
It's good for me.
All right, sounds good. So hi everyone. Today I'll be discussing a previous study that uses 4D CT to calculate global and regional left ventricle strain metrics to predict response to cardiac resynchronization therapy, or CRT. I will append left atrial strain metrics to see if we can improve the model. Therefore, my title is incorporating left atrial global and possibly regional metrics to left ventricular strain to predict response to cardiac resynchronization therapy, or CRT. So some background: CRT, or cardiac resynchronization therapy, is a well-established treatment for patients with heart failure and electrical dyssynchrasy, typically indicated by a YQRS on an EKG. The therapy uses a biventricular pacemaker that you can see here to synchronize the contractions of the left and right ventricles. The placement of both of these leads is believed to be very important for CRT response. So a significant challenge remains. Approximately 30% of patients do not respond well to CRT. This response is largely attributed to suboptimal patient selection and poor placement of the leads, like I just mentioned. As you can imagine, although it isn't an open heart surgery, it is an invasive procedure under anesthesia, so it can be prevented if not necessary. And therefore, it would be advantageous if we can use tools and metrics to better inform clinicians about probable patient response and optimal lead placement. While echocardiography and MRI have been used to improve lead placement, there are limited reproducibility or compatibility issues because MRI, a lot of patients have pacemakers, have prevented widespread adoption. Therefore, this study focuses on 4D cardiac CT to derive a new quantitative tool for guiding the lead placement. 4D CT is 3D CT over time, so it's a technology that can provide high resolution full cycle imaging of the heart. So I know there's a lot of information. I want to stick to the 3 slides, but let's go piece by piece. So the study I will be building upon was published in 2023 by Ashish Manohar under the mentorship of Dr. Elliot McVeigh, right here. In the study, the overall conclusion was that both global and regional strain metrics of the left ventricle can be used to predict CRT response. So let's go more in detail. So in the study, 82 patients, well, there were originally 182, but it got down to 82 after they made the metrics more consistent. But these subjects were from the imaging CRT trial and underwent 4D CT scans before and 6 months after CRT implantations. The authors retrospectively analyzed the data and used a 3D segmentation model to segment the left ventricle across 19 time points spanning the heart cycle for each of the patients. Here you can see the LV mask overlaid with the depiction of where the left, right here, the left and the right leads would theoretically be. Then moving on to the middle here, they then derived 4 global metrics from these scans, including end diastolic volume, end systolic volume, circumferential uniformity ratio, and left ventricular spherical index. They're global because they depend on the overall morphology of the left ventricle. The authors then split the left ventricle into 90 spatial regional segments and acquired 4 regional strain metrics for each of these regions. So that's a lot of values. But when training the models, they only use the regions below the left and right lead tips. So that's 4 from here, 4 from here, and then 4 global. So that's 12 features overall. Then the authors acquired the clinical features for each patient. So these are the features that would usually be used in the clinic to decide if the patients will respond well to CRT or not. So they appended the 12 to the 7 clinical features. So appending all these features, they then trained what's called a support vector machine. So this is a type of supervised machine learning model that finds an optimal boundary or a hyperplane that best separates data points into categories. Here they use it to generate, here's a little graph, they use it to generate patient-specific, what's called LPS or lead placement scores. This score quantifies how likely a pacing site is to yield a positive CRT response. So by assigning a global LPS value per patient, the authors could then define a threshold LPS score to binarize their population and predict either a good or poor response to CRT. So that's represented by this line here. Left is negative response, so they won't do well if they get CRT, and right is positive response, they will do well to CRT. And then the colors responder versus not responder, they define by end systolic volume difference between systolic and diastolic, which is also defined by this line here. So just to give you all some quick results from the study, an LPS threshold of minus 0.2, so that's the threshold they defined, gave an 82% accuracy AUC curve. That becomes important very soon. And then subjects in the top quartile had a 90% response rate, and in the bottom quartile had a 40% response rates. So in conclusion from this whole study, 40CT-derived LPS maps may help personalize CRT planning and avoid implanting devices in non-responders. So in my proposed project, I will look at the left atrium and essentially append that information to the left ventricle. In summary, I will compute global and possibly regional strain metrics of the left atrium and assess if they can better improve the AUC plot of the CRT prediction, whether by themselves whether appended with the LV values or whether appended just with the clinical values. So I'll try different combinations of that. In detail, in the flowchart, I've highlighted adaptations to the primary author, Ashish, his methodology in blue. So these are the things I could change. I'll see if I can change all of them. To begin, I'll use the same 82 patients with pre and post CRT 4D-CT scans. If the results look decent, I will possibly test on a larger data set. So I know we have a larger cohort of 500 patients that were also scanned in Denmark since the study was published. I'm currently segmenting all their scans as we speak, and I'm doing it locally, so pretty happy that my computer is not crashing with Zoom open as well. I provided a screenshot of ITK Snap showing just an example of an overlay of how the segmentation model is segmenting out multiple chambers of the heart. But what I'm looking at is now the left atrium and the left ventricle together. Next in my methodology, I'll compute similar metrics of the left atrium. If needed, we can use a pre-existing map of the left atrium and derive regional specific strain metrics as well. So that's the regional metrics. Using the LA global metrics and or the regional metrics, we will try different combinations with the left ventricle strain metrics as well as the clinical features to train the SVM. If time permits, I'll try different supervised clustering methods like the XGBoost, random forest. We can also bypass these metrics entirely and plug in the segmented volumes over time to some sort of CNN, RNN hybrid, since this is over time. For each of these variations methodology, we will essentially compute this AUC curve and evaluate if we can improve it from the 87% achieved in the previous study. Just to let y'all know, the 87% was when they combined left ventricle with the clinical. When they isolated just the clinical or isolated just the left ventricle, it was a little less. I think it was 77 and 82 respectively. So ultimately, we're going to try different combinations. And if we can get a value above 87, that meets the goal. So all in all, we're trying to see if the left atrium can be included to better predict response to CRT. That means it will be a process of trying different iterations of these blue variables and assessing if the AUC value will increase from 87%. I'm unsure if I'll try all the combinations, but ultimately I'm trying to see if I can at least append the left atrium global metrics to improve the AUC using the 82 patients and the SVM model. But I believe that's all I have. If you have any questions, I can take them now.
That was a very, very accurate and excellent review of where that technology is right now. So it seems to me like you've got it under your belt what's been done and why it's working. So that's great. And what I would add when you come back and show the results is why you believe the LA would have anything to do with any of this, right? So you're picking the LA to bring in. Why was that the first thing you picked as opposed to, the patient's, origin or anything else that you could measure from the patient, right? So, and that's about it. That's, so that you have like direct motivation for the LA data.
Okay, that makes sense.
Okay. And I'm always amazed at how young people trust computers that you would run a huge, background job on your computer while zooming into class.
Yeah, I didn't realize it was going to take 60 hours. I did the math wrong because it gives like time points. And I was like, oh, wow, that overlaps with Zoom. I only have one computer. We'll see what happens.
That's great. All right,
It's
Mark.
the M series. The series changed everything.
Yes, that's great. Okay. Na is next.
I'm ready. I'm gonna go ahead and share my PowerPoint.
Okay.
Is everyone be able to see it?
Yes, I can see it.
Or let me pull it out. So hi everyone. Today I will be talking about convolutional neural network or CNNs and can be used to suppress noise in medical image while preserving critical anatomic structure. And in clinical image, especially in like modalities like CT or MRIs, noises is a significant issue, and it can often introduce when we lower radiation dose to reduce the risk for patient. And while dose of image minimize the radiation exposure, it comes at the cost of increasing noises, which can obscure small but importantly diagnostic feature like lesion or vessel. In traditionally denoising technique such as Gaussian or like median filter to reduce noises, but they also tend to blur fine detail, which isn't ideal when diagnostic accuracy on the line. So because of that, for the core question dividing to this research is like, can CNNs effectively reduce noise while keeping the fine anatomy structure intact? And my main hypothesis is that CNA-based model can outperform classical method by learning to distinguish noise from real meaningful structure and medical image. And unlike traditional filters, CNNs are data-driven and they can learn complex noise pattern from training data and adaptively apply learn filter that preserve important detail while suppress unwanted noise. And one of the paper that I'm reading for this research is that this paper is writing by Chen at 2017. I including the citation at the end, so I will show everyone where they introduce RED, CNN, a residual and core decoded network that can significantly improve image quality for lower dose CT scan without compromising anatomy, structure, and then the image of it. And then we are moving on of how decided to like outline and plan for this approach is that to test this hypothesis, we plan to implement and compare three widely used CNN architecture, which is the UNet, the RED CNN, and the DNCNN. For the UNet, who originally built for biomedical segmentation, has proven effectively for denoising due to its encoder, decoder, design, and skip connection that help preserve spatial detail. And then moving on for the red CNN, as I mentioned, is significantly built for lower dose CT denoise and use residual learning to minimize structural distortion. And then for the last one, which is the DNCNN, while initially designed for natural image denoising, is also commonly adapted to um, medical application and use residual learning to predict and subtract noises. And then with that tree comparison, our data will come from publicly available low-dose CT datasets, such as the Mayo Clinic, the AAP challenge dataset, and where we have pair noises and clean image. We will train and test this model using patch-based train on GPU and evaluate them using standard metric like PSNR or SSIM. And we also consider like visual assessment by radiologists to ensure clinical relevance. For radiologist assessment, I will kind of like base I will use kind of like I will search for like scholarly article to use it because theoretically speaking, I don't have any radiologists. I know as a physician to literally kind of like scan through my paper. So I will use my best approach with scholarly article, and if by the time I submit a paper, I can be able to find one, I will ask for the opinion of it. And then the ultimate goal is to identify CNN architecture offer the best trade-off between noise suppression and preserving the anatomic structure of the image. And this has direct clinical impact by reducing the needed for repeat scan, enabling safer image protocol, and improving diagnostic confidence. And in summary, for me, like the CNN-based denoising hold a greater promise for improving medical image quality and patient outcome. And this study aimed to compare and then validate the method in meaningful way. Yeah. And below is some of the citation that I have been used to read more about my topic that I'm interested in. And one more thing that I'm trying to like add in with my presentation for the later on part is that I need to find a scholarly article to like clearly compare strongly between both the noise image and like the denoise image. You see the significantly different to prove the point. That's it for my part.
Okay, thanks. Um, Well, there's no question this is a topic that, every manufacturer is doing now, right? They're figuring out the best training network to denoise their images because neural nets denoise exceptionally well, right? They do a great job at it. A couple of things you should consider. One is since you don't have a human who's going to read this image, other than yourself saying, I like image A better than image B, um, the, there are a couple approaches to that. One is you create images that have a feature that is there or not there, and you get a human to tell you, is it there or not there, right? And then
Yeah.
you you know from the ground truth whether it is there or not, and how often the human gets that right. So that's one way of doing it. So you would create a set of pictures in which you made, say, something you want to detect in the lung. Well, I don't know what the low dose grand challenge images look like, um, but if there's standard CTs of a lung, say, you could put artificial lesions in the lung in the original picture and in the noisy picture, and then use CNN to get rid of noise and determine whether or not you can still see the feature. And when I say determine, that means you have to do it quantitatively. You have to have either a person try and find it or an algorithm go and try and find it, right? And then so that gives you some performance metric. Because right now it seems what we're missing is that at the end of this, at the end of your project, and when you present it, you're going to have a graph and you're going to show performance of each one of these methods. You
Got it.
need to know what performance is like. What does the graph plot? Like, what is performance, right? And so fundamentally, performance is like area under a ROC curve, right? So one will get, say, 84% of lung lesions, and this other smoothing only sees 79% because it smooths some away, that kind of thing. So I think that's your next step is to figure that out. What
Um, I'm like for my x-ray, right? Even though I don't know a radiologist, but I know an orthopedic, and I will kind of like ask orthopedic. So majority of my picture I will including it will be coming from like orthopedic. So I will
Okay.
try to like ask the orthopedic to like for example like some of the picture that this one is like patient confidential and being allowed to. Some of the picture that you have and you seen, can you kind of like pointing out for me some of the area that you're looking at, and then what is like the image like low quality and then good quality is? Like I will kind of like take in your advice and put in like two graph comparing like the algorithm from the paper that I obtained, and another one will base on his reading and his seeing to analyze like, okay, this is a good image and this is kind of like blurry, did not satisfy what I am
Right.
actually looking for treating patient.
So though that methodology, usually you ask the human to rank the quality of the image between 1 to 5, say. And that's called a Likert score, Laikert. And so you can look that up, how people would run a, a session for a human being to grade the quality of the pictures. It's not one of my favorite things to do because humans are, they're okay at that kind of thing, but there's a lot of noise on their estimates, right? But it's done a lot in imaging. You'll have physicians rank images from 1 to 5. So that's another thing. But the two of us can talk offline at ways you could set up that trial so that you get a quantitative result at the end, okay? All right, great. Thank you.
Got it. Thank you.
Sure. Terrific. So Jason, you're next.
Yeah, I'm ready. Uh,
Okay.
can you guys hear me?
Yep.
Okay, let me share my screen then. Shit. Allow. Wait. Uh, can you guys see the slides?
Yes, I can.
Okay. So hello everyone, I'm Jason. My project proposal is prediction of fluorescence image with bright field microscopy using conditional generative adversarial network, or CGAN for short. So we have to study the cells because many cardiovascular diseases begin at a cellular level, and many cardiological therapies start at this level too. Fluorescence images are gold standards of studying cells. With this kind of fluorescence markers, detailed structures can be observed within these cells. But these markers are harmful to the cells, and the cells can also be damaged by the light during imaging. This is called phototoxicity, by the way. These markers can also lose fluorescence due to prolonged exposure of light. This is called photobleaching. Also, we have bright field microscopy images, but bright field microscopy doesn't have this kind of issues, but the absorption of light is limited, so we cannot clearly see the structures of the cells. So limited information can be obtained. So how do we get more information from the bright field images? And is it possible to predict the fluorescence image from bright field images? In this project, I will try to use the conditional generative adversarial network to see if it can generate fluorescence images from bright field images. A generative adversarial network is basically a deep learning model with two networks, a generator and a discriminator. So basically, a generator, it can create fake data, and the discriminator can try to detect the fake data. They are trained together to produce realistic outputs. And a conditional generative adversarial network, or CGAN, is basically a GAN that receives extra information to control what is generated. So in this project, I will build a CGAN called pigs to pigs, described in this article linked here. And I will train it with a data set of grayscale cell nucleus images groups. So basically, in each group, there is a bright field image. This is a bright field image. And a ground truth image. I'm not sure if you guys can see it clearly, but here are some like stained this wait, I have to like so these are like the stained nucleus, and they can be observed like they are gray compared to the background. And so in each group there is a bright field image and the ground truth image. And I can track the Manhattan distance between the predicted image and the ground truth to see how real is the generated image quantitatively. Like there will be a chart, and there will be a graph to show us how many training steps. So there will be a graph of training steps versus the Manhattan distance between the ground truth and the predicted image. And we can see how real is the generative image by that chart. And at last, I can test the performance with a testing data set. So basically, that's all. Any questions?
Okay. So go back to your slide with your example there. This is so the bright field image is the bright field image of that same slice in the fluorescence image. I don't see features that overlap at all.
This is just an example. I'm not sure if they correspond to each other, but
Oh, I see.
the data set, I think every kind of like images are marked with a number. So basically, this can be like a bright field number one. This is a grayscale fluorescence number one. So I'm sure that means they are correspond to each other. Yeah.
So I would advocate for you to, when you're presenting this, to find examples where you can actually, look at the ground truth and the bright field in the same field of view so that there is some credence to the fact that this could happen at all, like that you could generate a fluorescence image from a bright field image. Obviously, there is some credence that you can do this, right? Because have probably tried it before. But unless I, as an imaging person, if I look at two completely different pictures and say, oh, this one is going to be pushed through a network and generate this one over here that has no relation to it, in terms of contrast or geometry or anything,
Mhm.
then it can't, I I can't understand how it works, right? So there should be some notion of why this should work in your argument that you're going to try and do it, as opposed to just pushing it through a training regime, right?
Mhm.
And then if I always advocate that if you do it and it's a very loose connection between the bright field and the fluorescence image, then you should also train it on random images that aren't the same object and see what that does. It might produce perfectly good fluorescence images that are just bullshit, right? Like that are just like made up all the time, right? So I think you probably want to figure out how that goes. Because right now I don't have any reason to understand or believe that this could work at all,
Oh, yeah, I see.
right? So why are you trying it? Is the question, right? I'm sure it's an interesting thing to do, but I have no understanding of why it could work at all. Right? So,
Mm.
but if you get some examples, right? And where you have the bright field and you have the ground truth and there are some features that overlap,
Oh, yeah, yeah.
you
That's
know.
samples and see the things.
Any other questions from the group? Okay, great. Beta, Samani, early detection of using Raman scattering. This is cool. All right. Is Beta with us? Ta-da, 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 ta-da. No, maybe
Yeah, I'm not seeing her name.
I don't see her here. Sorry. Yeah. Okay. Um, Cassie and Maggie, would you guys be ready to go now?
Yep, we can go.
All right, perfect. Thank you.
Mhm.
Okay. Um, Good morning, everyone. So today we'll be talking about our project proposal, which is simulating coronary artery calcium lesions. Okay. So as women ourselves, we start thinking about heart disease in women, and we found that spontaneous coronary artery dissection, SCAD, is one of the leading causes for death for women, and its incidence increase with age. So it motivates us to learn more about SCAD. And we try to find open data source, but unfortunately there is underrepresentation in data sets. And the causes of the disease are underdiagnosed as well. Although we know that there are three types of SCAD, each represent differently, such as through narrowing or rupture. But the small data set is still a challenge for scientific research. So in order to improve the delivery of care for women, we aim to simulating coronary artery calcium lesions so that we can provide more data for researchers. And we received some patient data set from Professor Dr. McVeigh, including PEC scores and CCTA image, both of which are imaging tools widely used in clinical practice. So for CCTA score test in particular, here's an example from a 55-year-old male patient with a calcium score of 0.625. And so the higher CAC scores are associated with an increased risk of death, but the score only reflects total calcium. It doesn't tell us how many lesions there are or where they're located. So this lack of information about the distribution of coronary calcium can be problematic. For instance, here in Plan A, the calcium is concentrated in a simple plaque, while in Plan B, it's spread across the coronary system, but both have the same score of 100. So this example shows that calcium distribution alone can lead to very different clinical implications, even when the total score is the same. And we found that location matters as well. So a small amount of calcium in a high risk area like LAD artery could be more dangerous than a larger amount in a lower risk region. So given these limitations of the CAC score, our goal is to output a detailed calcium map, not just the total scores, but special distribution of lesions, so that it can help researchers run better simulations and test hypotheses or trend models for personalized risk prediction. By doing so, we'll be able to get the limitation of women heart disease research. So this is our simple overview of what our model would look like. So first, we will input CCTA, the CAC, and the non-calcium score. And those are non-contrast image where you can see a bunch of bright areas. Then we'll use these image to first locate a calcium lesion from CAC, the non-contrast image. So the calcium would be the only bright dots that you will see in this image. Then the third step is to train a deep learning model that can learn how different calcium scores are represented in the image. And eventually, the model will output a simulated calcium lesion image that matches our desired score. And then Cassie will I'll explain more details about our simulations.
Okay, so for our project, we are using a CCTA data set of patients with coronary artery disease. So for each patient, a CCTA scan was done with contrast, along with a corresponding non-contrast coronary artery calcium or CAC scan, where the CCTA scan is going to be what provides the clear anatomical details. So that's going to provide contrast between the ventricles, and the calcium scan is going to give you information on the calcium lesions, where the calcium lesions are highlighted in that scan. So if you notice, these scans were done only minutes apart, but they do have slightly different field of views and possibly slightly different orientations due to things like patient movement. So one challenge that we're working on is the best way to map the information from the CAC scan about the calcium onto the anatomical details from the CCTA scan. So in order to make a model that can predict simulated calcium lesions, we first need to generate a library of reference data. So the first step to do that is to just segment the calcium from the data set. Like I was saying, because the calcium scan is non-contrast, this is actually a pretty easy task, as the only bright thing in those scans are calcium and bone. So we wrote a quick script to like determine the threshold for calcium, threshold pixels to isolate that calcium, and then it outputs a 3D binary segmentation of the calcium lesion. So we plan to do that process on our entire data set to generate a ground truth library that covers a broad range of calcium scores. And that library will include a CCTA scan, a 3D calcium mask, and a known calcium score. So once we have that ground truth library, which includes the calcium segmentations, we then have to align the calcium mask with the CCTA image, like I was mentioning. So after a few pre-processing steps, we're going to use this image registration transform tool in MATLAB to align the two images. So basically, this tool determines the mathematical transform that's necessary to align a moving image, which for us is that calcium mask, with a baseline image, which in our case is the CCTA image. So we're going to use this tool to properly align the images and then overlay them to determine that the calcium mask is properly mapped to that CCTA image. And then finally, to simulate realistic lesions in the CCTA images, we will use our ground truth library with correct mapping to train a model that learns the relationship between calcium score and lesion appearance. So given a desired calcium score, the model will generate an anatomically plausible calcium mask. So we're planning to use a convolutional neural network, such as a UNet, that will input the calcium score, the CCTA image, and the calcium mask as ground truth. And then the output will be a predicted calcium segmentation mask. And then that output, the predicted mask, is compared to the ground truth to evaluate the model's performance. So once we have the output from the model, we will use some post-processing to overlay and actually integrate that predicted mask into the CCTA image. So we're planning to work from this Medical Open Network for AI, or MANI, which is an open source library of models for medical imaging tasks. So two examples that used a convolutional neural network that we're looking at are this lung nodule CT detection model, and then this ventricular segmentation model. And so we're thinking that both of these examples could offer a good starting point to write a model for our specific purposes. I should mention that one limitation that we are already anticipating is that we will probably have a pretty small data set, which will lead to overfitting. And so we're planning on employing some data augmentation techniques, which after hearing some other presentations even, we're going to have to think about like which techniques are relevant. But things like elastic deformation, Gaussian noise, scaling come to mind. Manai has like an entire library of data augmentation techniques to choose from. So we'll have to go through those and probably employ some heavy data augmentation. And then another thing that we can try to use to improve our model's performance are computer vision techniques, which include implementing an autoencoder step in the model, which has been shown to reduce overfitting in a small data set. So that is essentially the general overview of our plan. Thanks for listening, and if anyone has feedback, we would definitely take it.
Great, thanks. So this looks like a great application for the GANs, right? For generating new, images that are tested to be viable or not.
Mm-hmm.
Have you looked into that, or
Slightly, like not in detail at all, just because neither of us are familiar with GANs at all. So we were kind of trying to lean into something that we've done before. But if you think that would be a better approach, we can definitely spend more time looking into that.
I think it would be worth at least an hour to read up and see whether
Okay.
or not this, generating these, because your fundamental proposal here is taking an existing CAC data set and CCTA, which has its own distribution of calcium,
Mm-hmm.
adding one number, right, which is like a new calcium score, and then generating a picture,
Mm-hmm.
right, a new data set. That's my understanding, right?
Correct.
Okay. So yeah, it seems to me to be the right setup for doing that.
Okay. We will definitely look into that.
Yeah. Does anyone else want to, who's done GANs before, want to pitch in on that? Or, but I think, it's a cool application for generating images from which you would um, test other things. Like, so if you want to test something that detects complex distribution of CAC, right? So the first thing you like when you started the motivation is, look, CAC shouldn't just be one simple number. It should have some kind of metric that is proportional to its distribution and its composition, that kind of thing.
Mhm.
And so to do that, you would need to see many, many cases of different distributions and stuff. So that's like I think I understand the motivation that way. Yeah. Cool. The tie between SCAD and this is now pretty loose, right? Pretty tenuous as far as I can tell. I know that's where you started, so you
Yes.
want to keep it there. Right.
That's kind of more of like a tale to how we got here, and also like yeah, like the whole motivation from the project started because we wanted to do something in women's health. And the problem was that like the data sets just aren't there. So like
Right.
kind of a loose argument, but like if you can generate whatever desired calcium score that you want, like that's a way of synthetically generating a data set which could be used for applications.
So I don't think you have to tie it only to SCAD, right? Because that's a really rare thing.
Right.
Coronary disease in women is a really big thing,
Mhm.
and they get it later than men. So if a woman is like 48 and getting a calcium scan, it is more likely that she will have a lower calcium score, and those lesions will be smaller and distributed, right?
Mhm.
Uh, so um, so if you want to scan women and men at the same age, you have to have higher sensitivity for calcium,
Right.
right, for the women. And which I advocate people getting scanned younger, because it's a very inexpensive, easy way to figure out whether or not you should consider standard techniques for reducing your risk. Okay, great. Um, so check in, I know I owe you guys some more data. I think we can check in on that and also the GAN stuff. I think it's worth going after.
Okay. Yeah, great. Thank you.
Thank
Okay.
you.
Right. And next, Ria and Shashank. We're
Hey,
doing
can you
genital.
hear us?
Yeah, I can hear.
Awesome.
Okay, great.
Let me share my screen. All right, hopefully you can see. Or can you see
Not yet.
now?
Yeah.
Got it now. Oh, that's Red Fox.
Okay.
God, I actually watched the original episode of this.
Oh, really?
Oh
That's
yeah.
amazing. Okay. So hi, I'm Shashank Bansal,
I'm Ria.
and we're gonna talk about, well, teaching AI to follow its heart defects. Um, so I think we'll start.
Yeah, to start us off, we're going to just quickly go through a bit of background involving why pediatric cardiac imaging kind of matters. When patient comes into a hospital for a variety of heart-related issues, cardiac imaging becomes really crucial in both diagnosing and developing treatment plans for them. Imaging not only reveals structure of the heart, but also useful characteristics like ejection fraction, as we've learned in class, and also flow dynamics, we've also learned in class. But there's a subset of pediatric patients which, due to a lot of embryological defects, have poor functioning hearts, and or also improperly formed hearts. So these are called congenital heart defects. Often these patients are in critical illness immediately at birth and require a lot of high quality imaging to be able to properly diagnose this issue, so they can treat it. So MRI is used a lot.
And then this is a difficult patient population because they have really complicated anatomy that can alter flow dynamics within the entire body system. So, as I said, MRI is often useful and can accurately capture a lot of this anatomy, and that could be really crucial for surgery planning. So that is the modality that we're going to be using for our project. Next slide.
Can we pause on this slide, this
Yeah.
case? This is remarkable that human beings, when you see cases like this, they're so resilient, right? That this person is still alive, right?
Yeah.
They show up at the hospital going,
Mhm.
I don't feel so well. And you look at that and you go, oh my God, it's no wonder you don't feel so well, right? But the is that a kid in
Um,
the case? I don't think
I
so.
think it's a male, maybe 51-year-old.
Yeah,
It
yeah,
was
yeah.
like very blurry in the like the actual, but I just found this very interesting,
Oh
the
my goodness.
sequencing.
Like look at this mass. It's
Yeah, it's right here, right?
forcing the valve, right, and dropping into the
Mhm.
LV.
Hmm.
That's an extraordinary case. I think you've got the LV and the RV reversed.
I
Uh,
was thinking about that because I
yeah,
was trying to find online like which one's LV, which one's RV.
yeah.
I mean, I the radiologist view is usually flipped, right? So they usually think of this as like they look at like from a patient view. So I was trying to like find which one's LV, like, but
LV, I believe, is the one on the right there. And then,
okay,
yeah, yeah, because you're usually
okay,
looking from the patient's feet towards their head,
yeah. To
right?
Oh, I see.
Yeah.
Okay, I had this issue with some other surgical
That's
data
all
as
right.
well.
Every
That's why.
engineer mislabels parts a bunch of times where they figure it out. Okay.
Cool. So continuing on to take a step back, we can understand what congenital heart disease is. Primarily, there's a high incidence of CHD, congenital heart disease, in approximately 1% of everyone. This is pretty high and it's significant because the vast majority of CHD is considered cyanotic, which is like the body is not getting enough oxygenation or it's poorly oxygenated. And so it has a very high mortality rate if not treated. This patient population until like recently we wouldn't really expect to survive until adulthood, but it's been increasing due to, um, well, a lot of diagnostic improvements and also treatment improvements as well. Um, and so there are over seven different, or well over seven different types of major cyanotic CHD. So a lot of standard diagnostic models fall short on relying, or fall short and end up relying a lot on expert interpretation. So that's kind of where our project need starts from. Next slide. So some gaps in current CHD models, current challenges in the imaging space is that we don't have enough accurate models given the high degree of complex variability. As I said, there's a lot of different types of CHD, and also there's a lot of different anatomical changes that happen in each different type of CHD. Adult pathology is often more uniform and is more widely studied, making the data very available. But given like a lot of low funding in pediatrics and incredible diversity of pathology, this makes having a standard model pretty difficult. When clinicians have to make judgments about treatment as opposed to the adult population who has robust evidence-based reasoning for decisions, pediatric cardiologists often have to use their like own expert judgment versus anything that is like, yes, there is CHD or no, there's no CHD. So that is kind of why we want to create a cardiac or CHD classifier, or kind of like a yes, you have CHD or no, you do not have CHD. And we're going to go into the methodology of that. Next slide.
Yeah, and one thing I want to add here is one of the
Mhm.
biggest problems with these models right now, I think Rhea mentioned was like there's no current model that says this is a normal heart or this is a CHD heart. There's a lot of debate about what a normal heart should look like, and which is why I think we're trying to figure out at least through AI models if we can find that. So so now exactly what our project will be, it will be a machine learning based classification of CHD from cardiac MRI we're going to start. We're going to use the congenital heart disease atlas, which is a diverse database of cardiac MRIs from children and adults with various CHDs. This was just collected. I think it was part of like UCSD and uh, like the, these are not just MRI data
Rady's.
sets. These are like more, Rady's Children's Hospital. And it was a collaboration between and another Starship Children's Hospitals in Auckland, New Zealand. One of the biggest data set for heart diseases um, or congenital heart diseases. And then it was just collected I think they finished collecting into 2023. We're going to focus on classifying tetralogy of Fallot versus normal CMR. Um, and I'll go into details why that is, why only one CHD for now. Long-term vision would be to develop more statistical or analysis or more include more CHD, like as Rhea mentioned, there's like 7. And then hopefully we can find some sort of like model that can identify subtle changes from a normal heart versus the heart with CHD. So this will be mostly our methodology. Um, as I said, data source we're going to use is the CHD Atlas, which was collected from different medical centers. Uh, because right now there are no tools to actually so when we're looking at the data set, there's actually no tools to do like major data sets. So I had to write a script to just like automate just like pressing on so you can only download one subject at a time. So I had to write a script just to download the data set. It took like forever to really just download the data set, but we are actually now successfully able to download the data set. There's 363 tetralogy of Fallot patients and 212 normal patients. We're gonna for pre-processing. So just a quick why we chose tetralogy of Fallot. So each patient has there's 4 for the tetralogy. There's 4 cardinal features that you would detect, which is ventricular septal defect, pulmonary stenosis, overriding aorta, and RVH, right ventricular hypertrophy. These are 4 features that you usually see in a patient with TOF. Um, these are very subtle changes, and it's usually very hard to find these. Um, each of our patient data comes with a few different MRI views, which include 2-chamber left ventricle, left ventricle, left tilt, 2-chamber right tilt. And this is, I think, a question also for Dr. McWay is like, so we have these several views, and maybe I should have added this to our slides, where we have 2-chamber views, 3-chamber views, 4-chamber views, a short axis view, and then we have like the end diastole and the end systole views. Not all patients have that. We have the nifties for these. I don't know if a combination of these would be good to classify these into either it's a TOF or not a TOF, or just we should just start with like 1-chamber, like 2-chamber view left tilt and see the changes between a normal patient and a TOF patient. So this would be something we're trying to understand what is the best combination of like views. But yeah, pre-processing would be segmentations. We already have segmentation for a lot of the patients, and then normalization of MRI volumes. Uh, then we'll probably try to model it based on a convolution neural network. I think Ria suggested we maybe use a ResNet or a DenseNet for feature extraction. And then finally, we'll evaluate using the standard metrics. And then, yeah, hopefully we can expand to, if we can successfully able to do TOF, we can expand to multi-class classification for other CHDs. I don't think Okay, hopefully we can incorporate some flow dynamics because CHD does have, or like QF does have some subtle changes in flow dynamics that might be useful. I think it flattens out like the pressure. There's some like very minute pressure changes. I need to look more into that. Um, Hopefully if we are able to build a decent enough model, we can collaborate with clinicians for real world deployments. Or you can even just first start with publishing our data set and show that yes, there are some subtle changes, and then improve interpretability of models for decision support. Thank you. Any questions?
Great. So I get it right. You've got 363 tetralogy of flow patients. You've got, I
Yeah,
forget, it was 100 normals or something.
312.
312 normals,
Yeah.
363 tetralogy patients.
Well, so there is a caveat. So in the normal CMR patients, not all of them they only have raw diacoms. Not all of them have a corresponding nifty, like structured nifty data set. I was thinking about creating just like, because each of them have like these different chamber views, but they also don't have any segmented labeling
I see.
for those parts. So,
I see.
but not all, it's like half of them I think have that.
Okay.
So I can start with just the ones which are labeled and then compare it to the ones which are labeled in TOF.
But going to a higher level of looking at all this as opposed to all the
Mhm.
details there. So at the end, you're going to have a network that you give it a heart and it says, I'm either normal, I'm a tetralogy patient.
Yeah.
Right.
Mhm.
So
Yeah.
two choices as the network. Okay. And so I'm trying to think of the use of that, but do these patients, the 363 patients, do they have clinical outcomes data, post-surgical clinical outcomes?
Uh,
I don't
for ex-
think so.
They don't. Do any of them have follow-up MRIs, post-surgical follow-up MRIs?
I post searched. I haven't seen them. I think they only have for now like pre-surgery.
Just pre.
Uh,
Okay.
yeah,
All right.
if I remember correctly, but I can
So then
check.
that's basically what you can do thus far.
Mhm.
But let's offline, we'll get together and discuss like the next level of analysis would be in that, because that's a lot of TOF patients, right? The 363 is
Yeah.
a
Mhm.
big number. So
Mhm.
it's a high
Exactly.
value. And I would say, uh, we should look at, is there any subset of those patients that, you could predict they're going to be really tough to fix, or a subset that isn't
Okay.
tough to fix,
Mhm.
they do really well.
Like severity.
Right. Right. Something
I
like that.
see. Yeah.
And
I-
just that it's informative for the team saying, oh, this is all, we got to pull out all the stops for this one because this is going to be a tough surgery.
Mhm.
The other great thing about this technology actually is that these people now you have people like in their mid 50s and in their
Mhm.
60s.
Yeah.
So you
They're
can
new
get
Well,
patients. They're brand
post-surgical, like,
new
yeah.
people, right? In terms of what you see, is somebody who's had a surgery.
yeah.
So if there's access to those data, that would be absolutely
And
cool.
I mean, we also, I mean, I think I mean, it will be very interesting to also see, for example, if you're just doing TOF, it would be interesting to see like sex differences or age differences
Right,
within like the cohort. So
right.
I'm sure
Yeah.
there's like if it,
I mean, that might have to do also with severity, like age differences, but
Maybe if they survived
Mhm.
to be older and then got it. Okay,
Yeah.
yeah.
great. Terrific. So we'll talk about that, but I would look and see if you have any outcomes data on the TOF of any description or
Okay.
I see.
post-surgical stuff.
Mhm.
Yeah, that would be great.
Yeah, for
Cool. I
sure.
think that's
Thank
it.
you.
Terrific. Thanks everyone for working hard on that. And I will get to work myself on getting you all data that I know you need. And never hesitate to email me and remind me what that data is. Right? Good reminders are good for that. And so now I think we only have like, what do you have, 3 weeks before the projects are presented? Is that right? So this is a pretty tight time scale now to get these projects done, but so it obviously it's a lot of fun though when they're done and they're done well. Because some of them launch theses and stuff like that, right? So
Yeah.
it's really good. Okay, thanks everybody for doing a great job. And We'll see you next Monday, if not before. Okay. So,
Thank you. Bye.
you.
Bye, guys.
Bye.
Hello.